Are we ready? We're going to talk about suck physiology today. Okay, so the number one thing that we must keep in mind is that the baby drives the system. These things right here, a lot of times they're just for show, but they also make milk. But most of the problems that happen during lactation are happening inside the baby, not necessarily inside the mother. And if it's happening inside the mother, it's because oftentimes of what's happening inside the baby. And that's especially true here in the United States where we have such abhorrent childbirth practices. Okay, and we have a bunch of babies who are being essentially and mildly tortured on their way out, and if you've been tortured, you're not going to be a very good feeder. Okay, so we're going to talk about what's normal, what should be happening, and then we'll move on to seeing a little bit of cranial work in action, and how to normalize an abnormal situation. Okay, so how do we define normal suck? And from the very get-go, I really want for you to appreciate how complex this is. This isn't just about, oh yeah, just put the baby on the breast and they're going to just do whatever. Well, they do whatever because of a very complex synchrony of multiple structures, multiple messaging systems that have developed over time in utero. Okay, so normal suck is a complex combination of precise synchrony of sensory and motor function with voluntary and reflexive feeding behaviors that coordinate sucking, swallowing, and breathing, and enable an infant to effectively transfer milk from the breast. When babies are born, after about 37 weeks of age, and maybe even before with the right kinds of support, they are perfectly capable of doing this on their own. The fact that they're not increasingly means that we're doing something to interrupt what is programmed in. Okay, so what does suck do? Well, it does a lot of things. It's responsible for development. It's responsible for brain growth. It's responsible for dendrite formation. It's responsible for proprioception and creating the map. It's responsible for oral facial relationships. It's responsible in part for state control. It's responsible for the digestive sequence. And it's responsible for helping to attenuate central nervous system function. Okay? We're not just talking about extracting milk. One of the most interesting things that I've heard in my neurophysiology meanderings, because it's one of my little hobby things, I like to read up on it, is that dopamine is pumped from the substantia nigra with each and every suck, and that dopamine is responsible for maturing the social nervous system. The nervous system we need to utilize to become compassionate, loving, and connected people. Yes?
Can you just repeat that?
Yeah.
Yes. With each and every suck, dopamine, a neurotransmitter, is pumped from the substantia nigra, maybe elsewhere, okay, because our knowledge about neurotransmitters is about this big, right? And dopamine is responsible for helping to mature the basal ganglia, the arrangement of various nerve nuclei in the brain, and midbrain especially, that is the social nervous system. And the social nervous system is the aspect of the nervous system that helps us to develop connectedness, attachment, compassion, okay, so that we're not sociopaths. All right, what's missing with autistic kids is the lack of development of this area. Okay, truly autistic kids, right? And then we have all these other influences that, create autistic-like syndromes. Okay, so SAC is doing a tremendous amount. And so it really scares me that now in my career, here I started in lactation back when, as somebody, I started as a molecular leader and I was working with, you know, mild disorganization, but I was there to help to support the mom and to support the babies in this really loving, you know, gentle kind of way, and I've landed 27 years later as being a therapist. And the reason why I became a craniosacral therapist is precisely because of the sucking problems that began to emerge about the time that epidurals really entered the scene in a big way. And I had to learn how to deal with that, because all of the things that I had learned in my master's program as a speech language pathologist were no longer working. Okay, so where we're headed with this is really frightening to me, because this skill, suck, swallow, breathe coordination, is the foundation of what goes on in development later on. So if this is not correct at this level, who knows what happens later? And we're just now starting to accumulate the data of what goes wrong. You know, we've seen it retrospectively. Of course, we've all suspected it in working with these kids. But now we're beginning to actually be able to quantify this. Okay, so this is so complex that it requires a ton of reflexes to support it. Okay, and we think about, you know, the one we hear about most of all is root and suck. But what we don't know is that we also have tongue extrusion reflex, we have phasic bite reflex, we have transverse tongue reflex, we have suck, swallow, breathe, cough, and gag, which are protective reflexes, and then we have movement reflexes, the spinal volant, the ATNR, the Babinski, and the pulmonmental. And all of that stuff about biological nurturing that you saw yesterday is when every single one of these reflexes are working, and they're working in precise synchrony. Okay, so now babies need to have good brainstem control in order to be effective communicators that they want to feed. And one of the things that is getting arrested by the use of our interventions in childbirth and maybe stuff that's happening gestationally in terms of the number of stressors that pregnant women experience nowadays, and then the combination of life happening is creating babies who go from 0 to 10 in about 6 seconds. Okay, they skip all of the adaptive state responses, and they're just going into complete and total HPA axis activation. Okay, and this is a problem because we're supposed to see normal avoidance and approach in babies. We're supposed to see state stability and the ability for a baby to be able to actually soothe self up to a certain point. Now, they do need some attenuation help from their mothers and some attunement help, but for the most part, they're supposed to be able to easily move through every single state and come back down and ask for help if they're having difficulty doing that, okay? And also to be able to control their levels of alertness. Unfortunately, lactation consultants will complain a lot about how, you know, these babies don't wake up. And now we have mother-led feeding, just like bottle feeding. The mothers are having to wake their babies up in order to get them to feed. And when they do, then these babies skip through all of their state control and go immediately into activation, and then they're not good feeders. And so the mothers go, well, maybe I just won't wake them up because this is becoming psycho-emotionally overwhelming to me, okay? So we've just got some real problems developing. Okay, our feeding exists within a framework. It requires the whole milieu. It requires the parents. It requires all good motor controls, good sensory input, good connection between the two, the baby's own organizational abilities, and of course, good physiology otherwise. So we think about infant feeding as a unit. It is suck, swallow, breathe, with the emphasis on breathe, because if you don't breathe, it doesn't matter if you suck or swallow, okay? So that's prime, and physiologically that's protected, and the baby will compensate with their sucking and their swallowing in order to protect the breathing piece. two channels we have one channel that feeds into two in order to enable, well, this is kind of Mother Nature's efficiency, by using one channel to do two functions. Okay, because if not, we have this really enormous structure here if we had two separate tubes. So the same tube is going to allow for both food and air, and maybe there's some other wisdom within that framework. But babies, when they're really, really little, have good apposition of these structures in here to minimize any kind of risk of food going into the air channel and air going into the food channel. So, but that presents its own set of problems, because if these structures in here that create valves to channel air into the right area and food into the right area, then we can get things all mixed up. And then we end up with aspiration, and then we end up with lots of air swallowing, or all kinds of other problems like that. And tongue-tied would be an example of how we can get some screwed up valving mechanisms going that don't set this up correctly. Okay, so what structures are involved in this? And you know, as I was going through this, I thought, oh, you know, I'm just going to present this really nice, tidy, sharp thing, and I'm going to be able to point to single structures and say, well, this does this and this does that. As I was delving into this more, I went, shit, that's not going to work. Because this helps, and this does this, and this does this. So I think we're so used to hearing about suck in isolation. You know, certainly lactation consultants, you know, we have experts like Mike Woolridge stand up there and present his ultrasound stuff, and Donna Geddes presenting her ultrasound stuff. And we talk about the oropharynx, and we talk about the pharynx, but that's about it. We don't talk about the rest of the body. And as craniosacral therapists, we got to talk about the rest of the body, because what's happening in the rest of the body is influencing what's going on here. And I think that's really part of the problem with lactation consultants, is that they don't really understand the bigger picture. Okay? So instead of breaking it down for you, I'm going to let you have a little journey in anatomy and physiology on your own time. And I'm going to present the broad strokes. How about that? And then when we get into physiology, we're going to be a little bit more specific. Okay. So, we have bones and cartilages, like cranial, vertebral, thoracic, and throat. How about that? Nerves, which include cranial nerves, cervical nerves, and thoracic nerves. And probably lumbar nerves as well. Okay, we have muscles that include scalp, orofacial, oral, and pharyngeal, neck, and thorax, and probably the hips too. As we had our presentation yesterday. Fascia, and I've recently kind of delved into this more. What is going on here? All lines and layers. How many of you are familiar with Tom Meyer's work as a model? Okay, well, what helped me with the anatomy trainings piece is to understand the connections in the recapitulation of structures up here and along with down here. So with what I was seeing down here, I was seeing reflected up here and vice versa. And the fascial trains really helped me to make those connections with my hands. And so especially dealing with tongue tie, we'll go over that, you know, more of that tomorrow. I was really feeling stuff happening and not having the words to explain what it was that I was feeling and why I was feeling it. And so the anatomy trains work helped me to articulate that better. So I hope that you find that to be true when we start to work on that. Okay, and of course we have the dura, the intracranial, and the dural tube. Okay? So, specifically, here are our bones and cartilages. Oh boy, starting to look a little more complex. Okay, lactation consultants don't even think about this typically. Okay? It's not tested. They're really not taught it. They're taught about a little bit of physiology, and they don't even think past that. Now, our ones that are italicized are ones of a special interest to us because they're key players. And as we work with infant suck, we want to trace these cranial nerves and their pathways for inflammation, occlusion, anything that could be impairing them talking to one another in a constructive way.
Hey, Alison.
Yeah.
What's nerve O or 0?
0. That's the one that has been quote unquote recently discovered, but actually they've gotten brave enough to, call it the 13th cranial nerve.
That's linked with the olfactory.
Right, that goes up into the brain. And what's significant about that particular nerve is that you're going right up into the frontal areas of the brain that are for orienting. So it makes sense that we've got a special channel in here that enables you to do that with your sense of smell. And that especially makes sense in terms of what the baby does, using their sense of smell to orient on the mother's chest and find her nipple. Okay, since vision is not the key player there. So I've been playing around a lot with the deep fascia, especially as it comes to tongue tie, and have really fallen in love with it. I think it's really cool to get into that area of the body and really feel its connections and its influences. And I'm certainly not an expert at it at this point, but it has opened up a whole new doorway for me in working with tongue tie specifically, and what's happening with the tongue, and to make a better differential diagnosis when I have my craniosacral hands on the baby to determine if there's actually a tongue tie present, a posterior tie specifically, versus some other type of problem.
What is the perineural network?
The perineural network is the myelin sheaths of the nervous system.
Thank you.
Okay, now this is a really crappy thing because in the middle of the night last night, I woke up with an insight. And I had my iPhone next to me and the tongue tie board, and I flipped to the page on the tongue muscles, and took my phone and took a picture and then uploaded it onto the computer and put it in here. So it's a really crappy thing here. But the reason why I wanted to put it in here is to let you know that there are multiple fascial layers in the tongue. All these fibers are oriented in lots of different directions in order to get the organ to perform its full range of motion, which is significantly huge in 4 dimensions. Okay, so we're having it move forward, sideways, up, down, and in time. That's pretty awesome. Okay, very complex organ, and it is an organ. It isn't just one muscle. Okay, and that's important to know. I know that Geddes really thinks the negative pressure is the major way of removing milk, but that's just a lie. And, peristalsis is remains a very important part of the process of removing milk. Okay, so 6 out of 12 or 13 cranial nerves are responsible for suck, swallow, breathe coordination. And those would be these. So when you're doing craniosacral therapy, you're tuning in to all of the activities of these various nerves in working in concert with one another. And I had a lot of fun when I was doing my embryology research and seeing how these various nerves grow and gravitate to their final resting places, creating their pathways. And because embryological formation is so different for each individual, you're going to find when you put your hands on babies that each one of them has their own unique pathways as well. And only generally are you going to find those pathways to be the same from baby to baby. So it's really important for you to stay open to having the nerve talk to you. Oh boy, if I said that in front of a lactation office. They'd all be going, huh? But it's so fun to relate to it that way, right? To relate to the body as if it's really truly got a voice, and that you listen to it in order to help you to make suggestions to it about what it could be doing differently. Okay, this is another crappy thing, but I did want to show you the nuclei and brainstem. And what we're seeing nowadays is instead of just having some motor control issues, that we're having brainstem-mediated sucking problems now. Okay, this is not just the type of neurodevelopmental issue that Marjorie Meyer-Palmer, the author of the NOMAS, Neonatal Hormonal Assessment Scale, was talking about, that indicates some sort of damage, permanent damage to the brain, or some sort of malfunction that's permanent. We're seeing these babies who look just exactly like those permanently damaged babies now, all the time, every single day. Okay, so something's happening with brainstem coordination with these babies.
So,
what?
do you mean that those are not brain damage? You're seeing both, and one population has more brain damage and one does not, so it indicates more brain stem.
It used to be that the only babies we saw with this kind of brainstem disruption were babies who actually had permanent damage. Now we're seeing a bunch of babies who, because of, I think the narcotics are a major player, but in terms of arresting the normal dynamic movement function of the body as it's being born, okay, disrupting this brainstem communication. I don't know how it's happening or whatever, because I don't know enough about neurophysiology to be able to say that, and maybe nobody knows enough about neurophysiology yet to completely explain it. I don't know, but if somebody's smarter than me on this accord, I sure do wish they'd start talking about it so I can learn. Okay? So I just am aghast at, the kinds of problems we see. Now, is that to say it's not recoverable? No, because subswallowed breath coordination is a developmental reflex. It's programmed in there, and we can recapture it. We can rekindle those relationships behind doing our cranial work. And craniosacral therapy is so effective at doing this. And I think it's really the king of modalities in working with these kinds of problems. Because we have the ability to talk in a different way with the brainstem in particular. Okay, so this third one is where the rhythmicity function comes from. And one of the main disruptions that we have with normal infant suck is something's happening to disrupt this pattern generator. Okay, again, I don't know what that is. All right, are we ready? Do you all have your water? Okay, so normally you just chew and swallow. This is an activity of daily living that you're not really meant to spend a whole lot of time being mindful of, although a mindfulness exercise is a really cool thing to do. Okay? However, you don't want to have to be thinking about this function. It needs to be at that rote, more automatic level. The other thing is that the act of observing somebody else engaging in an activity of daily living is a really interesting experience. And inside yourself, you will notice that when there are deviations from a normal rhythmical pattern, it will incite in you a response. Okay, so as a craniosacral therapist, when you're observing infant suck, it's important for you to tune into that aspect of yourself. It will tell you a lot. When a baby is not rhythmically sucking, you will feel your heart rate go up. Okay? It will engage your HPA axis. All right, so what did you just do? This is what you just did. This beautiful chart from Woolridge, which is back from the 1980s, they did ultrasound studies, one of the first imaging studies utilizing modern technology. There was one that happened, I can't even remember, Adriana Kemp back in 1970s, maybe? That was utilizing some imaging technology to be able to look at suck, swallow, breathe. Recently, Woolridge has reconducted with his colleagues a study because they were concerned about the new pronouncements about infant suck being largely a negative pressure thing. And so they redid the study using better ultrasound technology, and you've got some of that. He supplied it to me specifically for this conference. So we thank Dr. Woolridge for that. Okay, so we are starting up here at the tippy tip of the tongue. So put your tongue over your teeth. Let it rest against your lip. And then lift it up. Now pull it back slightly behind your teeth. That's the proper resting place of your tongue for a swallow in an adult. Okay, in a baby who is milk feeding, the teat is going to interfere with that, but the tip of the tongue is still doing the work, and it is initiating the sequence. So, a baby is going to gape, extrude their tongue, and then they're going to latch onto the breast, utilizing the tongue to do the latch. And they're going to suck the tissue into their mouth, just like you suck the fluid in, gently, and form a teat out of the breast. Okay, now, we like them to do as little of that as possible because a slurping like latch on is going to do damage to the nipple. And when they go on nice and deep, they're going to place that tongue correctly, and they're going to be able to initiate the sequence and create a little bit of negative pressure at the teat to start to open up the nipple pores. Okay? And then the progressive contraction is going to move a bolus along with the pressure differential, positive and negative pressure, creating a vacuum towards the back of the mouth. The nasopharynx is going to move up and close off, or the epiglottis. This structure right here that I can't remember the name of because I'm having a senior moment.
Uvula?
Thank you. Well, not quite. It's the soft pad. So, okay, it's going to close off the nasopharynx, and we are going to now close off the air channel temporarily as the back of the tongue, as Carol noticed in her cell, propels the bolus into the throat, and then the automatic peristalsis of this enclosed tube is going to move the bolus down into little spaces that are on the side of the larynx called the follicular spaces. That's going to, it splits the bolus roughly in half. Then the bolus drops, it rejoins in the channel that's going to go down into the esophagus, and then we have complete and pure peristalsis taking over that is completely involuntary, and boom, 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 down to the stomach, and then the rest of the gut does its thing, and we get this nice peristalsis thing until we eliminate, okay? And when babies are sucking properly, they're going to poop while they feed, all right? Which is a very good thing. It's a good thing we don't necessarily have to poop while we feed. In a baby, it is an ideal circumstance, yes.
When there's a strong letdown and that flow doesn't need to be pulled on, are they then just swallowing and not having that suction?
They may, and so one of the problems that we see developing with a baby who is trying to handle a fast MER is either they thrust their tongue, they hump it to slow down the milk flow, they cough, they sputter, or they just sort of let it roll. Okay, and they gulp and swallow as the milk comes in without doing a whole lot of work with their tongue.
Is that less ideal for them, though?
Yes, it is less
Getting
ideal.
all that coordination of their mouth and throat.
Right, because they're going to recruit accessory muscles to do the work instead of really having the tongue doing the bulk of the work. Okay? All right, so we have a series of valves working in tandem with the cranial nerves to coordinate this bolus, moving back and moving back and moving back, and then the back of the tongue ramping and pushing the bolus into the back of the throat for the involuntary swallow, and dropping it in just the right place for it to go down into the stomach instead of into the airway. Okay? One of the things that is easiest to see going wrong in a baby who is not sucking correctly is that these valves are out of sync. Okay, so they're not working in this really nice sequential manner. And that we call arrhythmicity. So, you want to see some video. Now this is a bottle-fed baby. Markers, so that they know where they're at. We're using a contrast medium here to be able to see. Here it is in slow motion. Do you see how it goes down into that little space? See it?
Yeah.
That's a little pocket, molecular space. See?
Yeah.
So it's at the base of the tongue.
Yeah.
Before it drops down, the little shelf.
Yes. Yes. How cool is that? Wow.
Wow.
All right, let's see it from the outside now.
When you show it again, would you show it, would you kind of identify,
The structures?
yeah. 'Cause I think I know what they were, but it's like.
It's really hard to see because structures that you think are like the tongue, etc., turn out dark on ultrasound and contrast medium instead of light. And in this particular thing, we saw the milk being dark, which was really helpful, okay? When we get down to the ultrasound video, unfortunately, it's really hard to orient myself. So what I want you to mostly look at is the rhythmicity. You can actually see the peristalsis, but you don't necessarily see the tongue doing its separate pieces in that.
Right, okay.
Okay, so here is on the outside. Okay, there's only one thing wrong with this picture. Does anybody know what it is? Okay, let's look again. Not supposed to see the lips. Look at the
Is she forcing?
breathing. Yeah. Okay, now why do you think that he may be doing just a little bit of extra activity with breathing there?
Because that milk was flowing fast.
Pause.
Right?
Hmm?
He was too close.
Was she pushing his head in?
He was too close. His airway was occluded slightly. So all that mother would need to do is to create just a teensy tiny bit of airspace right here at the nostril. The baby would breathe and calm down completely and everything would be hunky-dory because that baby was sucking quite well. Okay?
He's blinking his eyes too.
Yeah.
Like
Yes,
in-
that was the heightened ANS response to not being able to breathe.
Yeah.
Okay? Little tips like that, little things like that, that you want to hone your observation skills so you pick up on little things like that, helped clue you in to what's not quite going well. Now that baby looked good enough that a lot of people would just go, there's no problem here. Okay, because that baby's probably gaining weight, and that seems to be the only parameter that is utilized to determine if a baby is feeding well. Not so.
So the blinking wouldn't be happening like that if you were calmer or more comfortable?
Well, maybe, but that in comparison with the kind of heaving breath there as he was catching up during the pause is the indicator. Okay, you combine the two things and you can see that the baby's not doing well. Okay, now let's look at ultrasound. This is a breast baby. The bottle baby is a breast baby who was then, for the purposes of the study, given a bottle. And so what they found under those circumstances is if the right pattern of suck, swallow, breathe was established early on, then giving a bottle exhibited the same sucking skills. What they did not do is do ultrasound studies of babies who were bottle fed from the get-go to see what their suck would be like just because of the method. Okay? Okay, now the tongue is here. This is the breast. What I want you to mostly observe is the rhythmicity here.
This is the breast.
This is the breast. If I'm correct, which I may not be, that little bit of white is the milk particles breaking apart.
And the tongue is the peristalsis.
Right here.
Yeah.
Okay, so the throat's somewhere in here. Now, he was able to show all kinds of landmarks, and I'm going to have to watch this over and over again before I can, trace it out. But I just got these like 3 days ago. So can you see how, and did you notice how your body was just relaxed as you're watching it because you're just seeing this really smooth, rhythmical thing?
Well, it looked to me like in the first one with the bottle that the baby would suck 2 or 3 times before a little bolus of milk would end up, going down the throat basically. And this time it was every time.
Yes. Now, so babies will have their own style of how many sucks per swallow. We used to think that in the active phase of the feed, at the very beginning when the first milk ejection reflex occurred, that the baby was going to do 1 swallow per suck. That is actually not true. Okay, and babies will develop their own style from the get-go, and that depends on a lot of factors, like the size of the nipple, the compressibility of the breast, the baby's own hunger levels, how many calories they need at any given time, what size they are, what kind of inclination they have to eat, because we all have different appetite levels. So there are lots of things that go in to make up the decision of the baby's pattern. Yes?
Now, what I've always thought, and tell me if I'm wrong, is that I've always thought when babies sort of showed their preference, when they weren't getting that letdown burst of milk, but when they were sort of regulating it themselves, that most babies seem to prefer 3 to 4 sucks for every swallow. Do you find that that's not true?
They're finding that that is in fact not true. And that a baby will, there is this general trend, amongst babies that they're going to do fewer swallows per suck towards the end of the feed as they're getting more and more satiated. Okay? But there's constancy from the first feed onward, or the feeds that are happening in the first day onward. They kind of establish their own pattern, and each baby's going to be different. Now, we now know that there are different styles of mothers letting their milk down. So it used to be that we thought that the milk ejection reflex was happening at intervals determined by how much oxytocin was in her system, the oxytocin spikes, and that she would have a letdown in about 30 to 120 seconds at the beginning of the feed after the call-up sucking occurred, and then she'd have a second, and then a third, and then a fourth letdown as the feed progressed. We now know that there are mothers who will have 2 letdowns at the very beginning of the feed and then have no more milk ejection reflexes for the entire length of the remainder of the feed. Or she may instead have a milk ejection reflex towards the beginning of the feed that maybe occurred 5 minutes in, and then 20 or 30 minutes later have her second letdown. and have none between. Okay, so there are different styles of milk letting down that is not associated with the baby's sucking pattern.
Do we
Yes.
think that's a normal physiologic variation, or do we think there's some connection with Pitocin given to women in labor and because we think
Good.
that it changes the letdown pattern?
It's a good question.
Yeah.
And I think that there is a little bit more veracity to this because it was done in Australia where they don't do that routinely.
Sweet. Yeah.
So they were studying a more pristine condition of breasts
Yeah.
and mothers. But, right?
Yeah.
I mean, we're going from here. So, if we, hopefully, this is one of the questions that asked is, do we have an iatrogenic variation here? Okay, but nevertheless, in the studies, they showed these groupings of mothers. They fell into one of 4 different patterns. So,
And those patterns don't affect any other parameters. The mother doesn't affect somehow baby's weight gain or the baby's.
well, the baby really is the arbiter of the weight gain, both by genetics and by other environmental factors. So the nature-nurture kind of thing comes into play. And so, that we still don't have definitive answers on that, but there's no doubt that the mother and the baby are a team in determining what kind of weight gain is going to happen. That's in the presence of good suck-swallow-breathe coordination. There's a totally different answer to that question with the baby's not sucking well. Okay, because ultimately the baby drives the system.
But you don't think that a mom's letdown could ever lead to a baby not sucking well?
Oh, absolutely.
Okay.
Yes, absolutely. If you have too fast of an MER or too slow of an MER, then that baby's suck is going to change as a result. You betcha. Okay, let's look at the bottle. Here's the teat. Do you see? We can see the peristalsis much better here. Back in here is where the vacuum is getting created. Okay, so we have a pressure differential from the front of the mouth to the back of the mouth, and the milk moves down the pressure gradient. So higher positive pressure in the front and lower positive pressure in the back.
Am I imagining, or does it look like the back is a little more jerky with the bottle than it was
That's
with
what
the
I was
breast?
thinking too, yeah.
There is a slight difference between this and the other in terms of rhythmicity, isn't there?
Yeah.
Do you feel the response in your body?
Yeah, it's
Yes.
overwhelming.
It's like your body is going, and you want to try and make it click back into place. Yes?
To me, the soft palate has very little motion in this one, and it's like getting caught up in the nasopharynx a little bit.
And
Okay.
then
I'm seeing that right.
This
So-
looks like it doesn't have as much give, so
Yeah.
it's kind of pushing that up.
Yeah.
You may see an artifact of the milk delivery system here with the method of causing attenuation with the breathing. So the valving gets screwed up a little bit. Okay, so this, the soft palate, the nasopharyngeal valve right in here is a real key player in creating a rhythmicity. So if this is not swinging up and doing its closure, you're going to see ratchety kinds of breathing things manifesting. Something that you want to look for. Okay? And I'm going to show you the charts now of the rhythmicity. Okay, now, the upper one, oops, the animation decided to have a mind of its own. Let's go back, there we go. Okay, now, what we want is a normal pattern of sucking and swallowing and breathing working together, okay? So in a normally functioning baby, we're going to see the baby doing a really nice pattern of breathing throughout the sucking and the swallowing. A baby who has good rhythmicity will sound like this at breast. And that's because they inspire Okay, they take in a breath through the nose. They then suspend that breathing while they do the swallowing, and then they will exhale through the nose. Okay, so the sounds are the inhale and the exhale. Okay, a baby is going to be doing this 60 times a minute. They've got to be really well coordinated here. A baby who is doing one of these other patterns, see, holding the breath and then catching up during a pause, not good. Or doing this very irregular pattern here at the bottom. You see, where they're breathing in all these different places. Very bizarre. And believe me, you'd be going like, oh my God, breathe. You'd be trying to breathe for the baby if you saw this pattern happening.
And then also, I think I see a lot when babies are really starting to breathe, they have to really stop for a second completely, and then you see just, real visible.
Heaving, yeah.
Yes,
Yeah.
just catching their breath.
Exactly, exactly. And it really pains you when you look at it. Okay, now here's a really active milk ejection reflex, or one where the milk is just bursting forward. And I see babies doing more and more of this with the with mothers who are taking their placenta, with the capsules, the encapsulated placenta, where the milk supplies are just huge. It's a fabulous thing to downregulate a supply instead of having to build one these days. And so these babies are just going to do a little bit of call-up sucking, and then the milk ejection happens. And really, they open their mouths and they just sort of let it stream in. And they don't use their tongue nearly as well. These babies are going to be very gassy, windy types of babies because they're swallowing a lot of air. But they're also not closing off the vestibule in a way to prevent the air from getting entrapped. Okay? So they'll have some problems with some gassiness and bloating. Here, conversely, is a pattern where the baby is being very ineffective. Okay, so we have lots of call-up sucking with not a whole lot of swallows because there's not a lot of milk removal. This is a baby who is not exerting a lot of negative pressure to pull that milk out, okay, or not good peristalsis, so either low tone of the tongue or some sort of structural problem or some sort of miscommunication at the brainstem level. Okay, so by now you're getting the feeling that the tongue placement is crucial. So what I want you to do right now is to place your tongue at the back of your teeth, having the tip resting up at your palate, your hard palate, okay? Close your lips gently. Don't purse them. Just let them rest and swallow. Now what I want you to do is to clench your teeth together and try and swallow. What happened?
I lost suction.
You lost suction?
I think you would have gone at the sides.
Okay.
You have to hump your tongue to get it to do what it should normally do smoothly.
Okay.
You have to pull it back entirely from the normal resting place.
Okay. You had to pull yours back, right. Okay, so now what I want you to do is to purse your lips. And notice what happens with your tongue.
It's hard to form a central groove.
Yes.
Hard
Tension.
to do anything.
Yeah. Notice again, I want you to do it, just have your jaw relaxed. And then purse your lips and notice what happens with your tongue. Does your tongue go backwards? Uh-huh. Okay. All right, so baby who's not latched on correctly and is pursing their lips a lot, guess where the tongue is going to be? Back in the mouth. It's not going to do a good job of peristalsis or generating that pressure differential inside. Big problem. Okay, so this is what good placement looks like. Now, of course, we're artificially pulling the breast back so you can see. are not accurate. Now Mama's gotten in there and is messing around because she thinks that she's going to make him continue to suck this way, instead of just following his cues and letting him do what it is he's supposed to do at that part of the pee. Okay, so you saw good tongue function there. All right, this upper lip was not like this at the breast. Okay, so we're not aiming for that, and this is why the maxillary tie thing is, you know, let's be judicial here, judicious about whether or not we're going to do this, because we do not need to have this lip plunging like this. Okay, and we don't need to have this lip plunging out like this. Although it is true that if the lip is sucked out like this, then the tongue is back. Okay, so if it's up and starting to roll in, that's not good. But we don't need fish lips.
Can I ask you a quick question?
Yes.
When the mouth spasms like that and
Clonus.
is that a sign of a loose jaw or?
No. That is either immaturity of the system or the baby starting to get tired. And now, when we do video, it's like a reality TV show. It's scripted. Okay, it's not really reality. And so we were pulling the breast out of the baby's mouth, and the baby is like going, hello, now I got to exert a lot more, effort to maintain my seal, and he got tired from it. Okay, that would not have happened because I had observed this baby feeding at other times, and he didn't exhibit that clonus. So that was just exhaustion happening.
You can see that happen with tongue-tied baby, right? All that effort to.
Some of them do a lot of chronic movements like that. Yeah. Okay, so let's see. Would you rather see cranial, do an exercise where you're observing your neighbor and putting your hands on them as they're doing their straw and chewing and all of that, or see some treatment video? Treatment video. Okay.
We can do that exercise at lunchtime.
Yeah. And I do encourage you to actually put your hands on somebody else so you can feel these structures working and feel the rhythmicity or not happening, and really get a sense of what are the structures doing in here, okay, including the highway bone. Because that's going to help us build for tomorrow, what we're doing with the tongue tie. Good. All right, now typically what I have found over doing maybe almost 8,000 treatments, most of them on infants under about 6 months of age, that it takes me about 30 to 60 minutes per treatment, depending on what the baby is capable of handling, without being thrown into chaos land in terms of integration, because I like to be sure I get really good integration after each session. 2 to 8 treatments with an average of 4 when I'm working with a sucking problem, more if the baby is vacuum extracted. And 2 to 7 days apart, and that depends on where we're at in the treatment sequence. Okay, so because there is urgency with breastfeeding, all right? We're racing against the clock, and that clock is the psycho-emotional status of the mother in the family, who in this country are very quickly going to wean their baby from the breast if they don't get something happening, okay? So unfortunately, we may have to push the agenda a little bit in order to accommodate the other issues that are present. When I'm doing moms, if I'm only doing a little tidbit, oftentimes when I'm holding space, I hold space for the mother to release while I'm working with the baby. So energetically. And so oftentimes I'll get some result with her as I'm working with the baby without having to put my hands on her. But if I'm going to work with the mother specifically, like she's had an epidural like most moms do in the United States, maybe not here in this locale, but definitely where I'm from, 99% epidural rate, just to start to free up her dural tube from the puncture wound. You know, it's huge. I mean, talk about postpartum depression, you know, you free up that dural tube and get the cranial base operating, and, you know, you can go a long way towards eliminating that problem. And I'll work with her as many times as it takes to resolve the chief complaint that she has. And again, 2 to 7 days apart. Sometimes I'll just, you know, like go up to her and just, you know, put my hand on her, and while I'm just talking to her, you know, start to do a little bit of work. You know, in order to just take care of one little tidbit. So when you're working as a lactation consultant, you have so many things on your plate that working the craniosacral therapy in is an art form, and you figure out how to do it whichever way that you can. Okay, now, contraindications are a fresh brain bleed or stroke. You wait until you've got some healing. If you have a really unstable infant that you are concerned is not going to be able to integrate the work, hold off. If there are CSF issues, yeah, that's a relative contraindication, but you gotta, because you may be able to help resolve some of the CSF issues, but you may not be able to, so you want to be careful. And of course, parental objection, which I always give permission. Alrighty, let's look at some stuff. Start with the breech, one of my favorite, Lisa. She had abnormal molding and torticollis because she was breech and her head was stuck up in the mother's rib cage. At 3.5 weeks, she came in to see me. She was frank, and she had those chopstick legs, and you're going to see those, you know, just right up here next to her face. She was born by a C-section, so we had some other, you know, in addition to the hip stuff going on because of the breech, we also had hip stuff going on because of the C-section and the way that they had to pull her out. She resolved in 2 treatments in terms of the sucking piece, okay? But she was pretty messed up when she came in. Owies. This is nipple compression causing neuralgia. This is a sharp shooting pain, burning post-feed, often mistaken as thrush, not thrush. Okay, see the chopsticks legs? Now, I do a lot of finger feeding with these babies while I'm treating. If they're not at breast, me doing a treatment, then oftentimes I'm going to do some finger feeding, and that way I'm able to work with my finger inside the mouth at the same time that I'm doing work with the other hand.
Why does she have the chopstick legs?
Because she was breech. That's her proprioceptive map, right there. Okay, now, you're seeing her being activated by what I'm doing. This is good, not bad. Okay? This is generating energy to push her into a change.
Are you working inside the mouth? Or
Yes.
more in the head?
Both. Okay, I want to get the cranial base to release. I'm going to work on membranes inside there. I'm holding a whole, big space for all of that to happen just with my index finger.
And she's getting food through that little thing.
Yes.
Through something.
Right, exactly, with that device.
So do you just convey that to your parents before they come in to?
Yeah, we talked about
breast milk?
I said, yes, I tell every mother, bring in a couple ounces of breast milk with you if you have it, and that's what we're going to use in case I
Gotta
need
make
it.
it a lot easier for babies.
Yeah.
I joke all the time, if I could get breast milk flavored gloves, my work would be so much easier, but.
Right.
You know.
So she had a polarity shift there, and all of a sudden, this baby is able to begin to generate a normal proprioceptive map, because breech babies oftentimes have their positive down here and their negative up here instead of vice versa. Okay, so we got that nice shift, and when that happened, her midline emerged. And when the midline emerged, then she started to work from her midline, and that's why it only took us 2 treatments. Okay, I'm checking all the sutures. Now we're going to directly get to the core issue. And once we had that release, the suck changed. Can you see it? Before she was just kind of dilly-dallying. And now all of a sudden she's applying herself to the feeding. Now you may or may not be able to see. Yep. Now I'm just checking it out to see how much result we got. And we had about a 50% change, but now you can kind of see where it's indented there from being up in the rib cage and having the bony compression against it. See it?
Yeah.
Did she have any other neurological issues? Her ears are interesting. Did she have any other?
No. Okay, this is after 2 days. We had resolved the nipple compression syndrome issues. The mom was only having latch pain. So substantial difference in 2 days' time.
See the ear move now.
That's right, the temporalis is moving, so we've got much better trigeminal nerve function here.
She feels so much softer.
Yes, much less tense overall, way more satisfying feeding. I mean, we still have some things to do, but okay. Let's see, do we have time for a quick other?
Oh, we want all of them.
Yep. Well, okay, well, unfortunately, I can't show you all of them. Okay, you have your choice, vacuum extraction, torticollis, tongue tie.
Vacuum.
You want them all. Okay, let's go here.
They're great, definitely.
Okay, so she was vacuumed during a planned C-section. You get it. 5 weeks old when she came in to see me. Mom had a low milk supply, as you might suspect, and she wasn't gaining well, as you might suspect, okay? And this resulted in 3 treatments. This is a mother who is showing examples of all the things you're not supposed to do. Okay, we're having an awful lot of activity down in here where it shouldn't happen. She's recruiting an awful lot of accessory stuff. Can you see it? Right there. Okay, vacuum extractors are designed to create what's called a chignon. Okay, it leaves its imprint. So I'm determining exactly what's gotten sucked up into that little chignon area. And I'm helping the mother to experience what that is because she noticed it, but she didn't know how to place it. Sorry? Well, see what's happening here? This is all aversion. Baby's going, yeah, I'm not liking this, no matter what. And did the same thing at breast. You know, just really pulling off a lot. Okay, now, this baby did such a great job of like putting herself into all of these positions to integrate the changes of the cranial treatment. It was really cool. Okay, she's starting to like, she's starting to get it. It's re-emerging. After every major change, she would do this kind of stuff, and I just kind of followed it. Can you see the difference?
Can you say what you did for that treatment? Or you just did a molding back there to let that?
I was just following the system. I can't remember specifics of any given case. There's, you know, look at the difference here. I had to work with the mother a lot on learning how to handle well, we don't want a backwards head tilt. Not really. You want that tongue placed correctly. The tongue's going to do the work. So when you have a nice big space in the back from the tongue creating its negative pressure in the back of the mouth, you don't need that head tilt. Okay?
Allison,
Yeah.
I want you to also really stress to everyone here that doesn't do infant feeding, how therapeutic finger feeding is different than just babies who are sent home finger feeding for 3 weeks.
Oh, yes.
So don't, people might watch this and think like, oh, finger feeding is the hallelujah moment, and just stress
right.
that that's not.
Finger feeding is an alternative feeding method that is designed to create a stopgap measure while you're working on resolving the underlying problems. It is not a method of feeding. It is therapeutic in its value, okay? And the reason why we use finger feeding is because it is the closest we can get to eliciting the right kinds of motor movements to the breast, but it is not exact, okay? So it really is, you must be judicious in your use of it.
Do you wait until the bruising subsides before you initiate treatments?
No, heck no. I do not wait at all. If there's like subtle hematoma, oftentimes that blood gets trapped in there and you just get all this pressure. And so, there's not good drainage because you don't have the vascular system operating correctly inside the head. And so trying to get as much space in there and influencing the vascular system to drain properly will help for the subtle hematoma to go down. Okay, but I also use cabbage, green cabbage, to reduce the swelling.
Just like on a breast?
Just like on a breast, I put a little bit of green cabbage right over the caput. Yes.
I was just going to add something to that, but I have a colleague back in Indiana that's also trained in Carol that worked with babies that had the real bruising, and visibly while she was treating the baby, they just watched the blood resorb and disappear. They watched the bruise disappear, and the parents were, remarked on it. It was that visible.
Yeah, it's pretty stunning when you have those really major, like, whoa, where you as the cranial therapist, when you're used to seeing miracles happening in front of you, that happening is like, whoa, that's really cool. But you can't expect that kind of drama to happen every time you're working on a baby, right? Okay. And the reality is that working with babies, they get upset while you're working with them. And you have to not be afraid of their upsetness. You just support them in their upsetness. And when some of the work that I do, people go, oh my God, you're not helping that baby get organized. Well, I want the baby to have the freedom to go into their dysfunction. They go into their dysfunction and like the up-ledger concept of the stuck drawer, which I think is a beautiful one, go farther into the dysfunction, give it some energy. Perturbate. And when you get that energy, as in chaos theory, you have a chaos attractor, you want the chaos to reorganize. And you have to have energy to do that. So I let the baby find that space. And then we marshal that energy and we use it to make the change. Does that make sense?
Yeah.
Yes.
I'm ignorant. Why in the world during a C-section would they use a vacuum?
Beats the hell out of me.
I can answer that.
They can't get them out.
No, I can answer because I had this conversation with my doctor. They'll use it because it's an easier way to get the baby out, easier for the doc. And also, if the woman is larger, it can sometimes be harder to get a hold of the baby, so the vacuum is considered to be easier for that reason. But so many women don't even know to ask that question of their doc if they're anticipating a C-section or if they're wanting to, in my case, I was a scheduled C-section, and fortunately knew enough to ask my doc that question, but most people think it's a C-section, so at least I don't have to worry about use of the vacuum, when unfortunately that's not the case.
Yeah. So this was highly unusual. I had never even heard of such a thing before, and when this baby was in such bad shape because the vacuum extractor, in addition to all that monkeying around with the Atlas, You know, it was like double whammy, triple whammy. It was horrid. It took me a while to really work with that. Yeah.
I have kind of a scope of practice type of question.
Yeah.
I have an oral certification, so that's all good. Would you say that doing a feeding like that would need to be some teaching, some coaching as to how to do that properly?
You mean to finger feed properly?
Finger feed, yeah.
A
To
little
use
bit.
that as a tool.
A little bit of coaching is all that's necessary because finger feeding is really easy to perform. So if I can get a parent to do it in, 2 minutes, certainly a therapist is going to be sensitive enough to be able to learn the method and then to very gently experiment with that method in a way that's productive during a cranial session. I try and do as much as I possibly can at breast, but obviously you're seeing mothers who have these nipples that are torn up, and they're not wanting to
And if
feed.
you weren't going to do the feed, would you just go up and work them out without the feeding tube, without the finger feeding? Or is it preferable to do the feeding so you get that whole sense of the hard palate and soft palate and everything working?
I very rarely will do mouth work on a baby without also having a feed going.
I think the quality of the stuff changes with women.
Yeah. And you're occupying that baby and you've got a lot of energy moving and going, with that. And so you can marshal that energy for change. Yes.
What do you think about pacifiers?
What do I think about them?
Like what do you tell the parents?
They're mother substitutes.
Thank you. I get so tired of hearing moms say, oh, I feel like a human pacifier. It's like, no, the pacifier is a substitute for you. You are not a substitute for the pacifier.
Yeah, so really basically there's a ton of research on what happens. It's a pathway of infection, number one. Now, a little bit of stimulating the immune system is a good thing. So, babies crawling around on the floor and sticking their fingers in their mouth, okay. So that one may be a relative, ridiculous notion, but it creates a different kind of brainwave function. So when a baby's sucking on a pacifier, they go into a trance state instead of the kind of natural rhythms that get developed in an alpha rhythm and maybe a theta rhythm while they're sucking at breast. So from that standpoint, and I think we'll find out more about pacifiers if we were to study them from the perspective of what happens with the brain.
In other words, you don't approve of using a pacifier even as an exercise equipment?
Oh, goodness, no.
Okay.
However, bottle-fed babies are a different category of baby. They're not breastfeeding.
Right.
And so when you're working with a bottle-fed baby, you're already compromising whatever, and so you're utilizing a different set of tools. But in terms of using the pacifier, pulling it out and whatever, why can't you just breastfeed them? For a breastfed baby, why use a pacifier to do what the breast is supposed to do? And the tongue is supposed to do at breast as the form of exercise. See?
Gotcha.